Hello everyone, I'm Dr. Arash Shahravan. I work as endodontist, a dental researcher, a professor at Kerman University of Medical Sciences. I've published over 90 research papers, and my goal is to help you use new dental science in your practice. To our regular viewer, thank you. Your support means everything. To new viewers, welcome. You are just in time. In this video, we'll look at important new endodontic studies from March 2025 and see how you can use them in your clinic. I've carefully selected these studies, including new techniques and practical clinical tips to help you in your daily practice. Whether you are a specialist, general dentist, or a dental student, you'll find valuable insights here. So grab your favorite drink and let's discover together how these latest findings are changing our field. As an endodontist with nearly 25 years of experience in root canal treatment, I believe one of the leading causes of tooth extraction in endodontically treated teeth is crown fracture. The loss of tooth structure due to caries, previous restorations, and endodontic procedures significantly weakens these teeth, reducing their ability to withstand mechanical stress. This is why the quality of the final restoration is just as critical as the endodontic treatment itself when it comes to long-term tooth survival. In a molar with at least 3 remaining axial walls, which restoration do you prefer? A direct composite resin or a full coverage metal ceramic crown? Alright, let's dive into a compelling clinical trial with a 3-year follow-up on this very issue. The study published in the Journal of Dentistry by Motassem Abu Awad and colleagues from Jordan, and the title is Direct Restorations versus Full Crown in Endodontically Treated Molar Teeth, a 3-year randomized clinical trial. The study included 60 participants, each with an endodontically treated molar retaining at least 3 axial walls. Half received direct composite restorations, while the other half got metal ceramic crowns. Here is what they found. Crowns had a 93.3% survival rate after 3 years. Direct restorations came in at 76.7%. Now the authors noted the difference was statistically insignificant. The p-value was 0.061, but in clinical terms, I know the sample size wasn't enough to show the difference between groups, and I would like to call this marginally significant, especially since crowns showed clear advantage, particularly for bruxers. That said, direct restorations may still have a role. Think lower occlusal load cases, teeth under monitoring, or budget-sensitive scenarios. Alright, let me introduce you to a valuable journal, and then we'll discuss one of its recent papers. Have you come across the Evidence-Based Dentistry Journal before? This journal features key studies from other dental publications, but with a unique twist. It focuses on high-quality evidence like randomized clinical trials and systematic reviews and summarizes them into concise one-page summaries. This makes it easy for clinicians to stay updated without spending hours reading long articles. Now, let's dive into one of their latest papers published in March 2025. I'm sure you are familiar with the Epical patency technique during root canal preparation. In this technique, we use a small K file like a number 8 or number 10 passed about 0.5 millimeter beyond the apical constriction to prevent dentin plaque formation, especially in curved canals. But here is an important question. When the file extends into the periodontal ligament space, does this technique increase the risk of post-operative pain? Let's explore what the latest research says. Now, let's dive into a commentary paper from Evidence-Based Dentistry Journal that summarizes a systematic review and meta-analysis titled "Does Achieving Epical Patency Increase Postoperative Pain During Endodontics?" This paper, led by Rachel Strickland and colleagues in UK, analyzed data from patients aged 14 to 65 with conditions like pulp necrosis, apical periodontitis, or pulpitis. Their research included a variety of irrigation solutions, from saline to sodium hypochlorite, EDTA, citric acid, and chlorhexidine, and focused on both molars and anterior teeth. All studies used a number 10K file for apical patency, along with various hand and nickel titanium instruments for canal preparations. Now, here is the surprising part, at least for me. The review found that maintaining apical patency actually reduced postoperative pain slightly. This effect was statistically significant in the first 24 hours and at 2 days. However, by day 7, the difference was no longer significant. So, contrary to what some clinicians might expect, apical patency didn't increase pain. It lowered it in the critical early stages. Pretty interesting, right? Today, I want to discuss a crucial position statement published in the International Endodontic Journal by the European Society of Endodontology. This landmark paper comes from none other than Dr. Shannon Patel, one of the world's most respected endodontic researchers, and his esteemed colleagues, focuses on longitudinal cracks and fractures in teeth. While I highly recommend reading the full text, let me summarize some key points for you. First, let's clarify some terminology, and let's start with crazed lines. What exactly are they? These are superficial cracks confined to the enamel. They don't compromise the tooth structure integrity. They are typically asymptomatic and usually don't require treatment unless they are stained and affect aesthetics. Now, let's talk about cracked tooth, a more serious condition than crazed lines. What is it? A crack that extends into the dentin, deeper than just enamel. The depths and size are often unknown. It may even go subcrestally. Pulp involvement is possible, depending on how far the crack extends. What is its clinical presentation? Symptoms can vary widely based on location, size and extension, and pulpal and periodontal status. Treatment approach consists of removing the crack, protect the crown by a cusp coverage, and root canal treatment only if the crack reaches the pulp. Periodontal treatment needed if the crack extends into the periodontal ligament space. Key takeaways: early diagnosis is crucial. The sooner we detect and treat it, the better we can save the tooth. Let's break down fractured cusp, a common type of tooth fracture. In molars, a complete or incomplete fracture that runs along the buccal or lingual groove and in mesiodistal direction of the affected cusp. In premolars, typically involves fracture of the marginal ridge and the critical factor. Pulpal involvement varies. Some cases may only need restoration, while others require root canal treatment. And again, we must consider periodontal involvement. What is a split tooth? A split tooth is a complete fracture where the tooth is visibly separated into two distinct segments, typically running in a mesiodistal direction. In these clinical photographs from one of my cases, you can clearly see a classic example of a split tooth, and unfortunately, the treatment plan was extraction. Now, let's look at another type of longitudinal crack, the vertical root fracture or VRF. This is an incomplete crack running lengthwise along the root, affecting multiple layers, cementum, dentin, root canal space. While extraction is typically the only option for vertical root fractures, Selected cases can be managed surgically by removing only the fractured root segment and preserving healthy tooth structure. In these photographs, you can see a case of vertical root fracture where I performed pre-radicular surgery as exploratory surgery. Then I decided to give another chance to the tooth and I cut the mesial root until reaching sound dentin. The 6 months follow-up shows healing in both photo and radiograph. Finally, we have a split root, a complete vertical root fracture, where the root is visibly broken into 2 separate parts. This CBCT scan clearly shows a split root in my patient. You can see the complete vertical separation of the root into 2 distinct fragments. As many of you know, I have a special passion for periradicular surgery. It's where precision meets artistry in endodontics. That's why in every video I make sure to highlight at least one groundbreaking surgical study to push our skill forward. We all know irrigation is critical part of cleaning during root canal treatment. But when it comes to retrograde preparation in endodontic surgery, there is surprisingly little focus on irrigation and cleaning protocols. That's why a recent case report by Dina Abdelatif and colleagues from France and Italy caught my attention. Published in the Journal of Conservative Dentistry and Endodontics. This study introduces an innovative approach titled A New Cleaning Protocol in Minimally Invasive Endodontic Surgery, RUA or Retro Irrigant Activation Technique. This protocol aims to improve cleaning efficiency during periradicular surgery, an area that has been largely overlooked until now. Let's take a closer look at their technique. After making a 3 mm retro preparation with ultrasonic tips, instead of just using normal saline like in traditional techniques, they introduced a multi-step chemical cleaning approach. First, they applied 17% EDTA gel and activated it ultrasonically for 20 seconds. After rinsing with saline and drying with paper points, they then applied full power sodium hypochlorite gel. Then they did ultrasonic activation in 3 20-second cycles. The cavity received a final flush with saline using a precise 30-gauge needle. But here is what really excites me about this technique. It's not just about better cleaning. This protocol may allow for more conservative treatment overall. Surgeons might only need to remove 1 mm of the apex instead of the traditional 3 mm. That means we can preserve more tooth structure, which is especially crucial for teeth with unfavorable crown-root ratios, where every millimeter of root length matters for long-term prognosis. Let me summarize the key takeaways from this innovative RUA technique. They use EDTA and NaOCl in gel form instead of liquids. This gives us better control with less risk of extrusion into surrounding tissues while maintaining the powerful cleaning effects we need. And the gels were activated using small, smooth ultrasonic tips, and this ensures effective cleaning while minimizing tissue irritation. This could be a real game changer for our surgical endodontic cases, especially when dealing with compromised teeth. Thank you so much for joining me in exploring these groundbreaking endodontic studies. If you found this video helpful, smash that like button, subscribe for more evidence-based endodontics. Hit the notification bell so you never miss an update. Your voice matters. Drop a comment below with your thoughts or questions. I read and respond to every message. Keep pushing the boundaries in your practice, and I'll see you in the next video. Stay curious, stay innovative.